series. What do you want to know about?
All right, great. Okay, so
Ready?
we're on, so whenever you want.
So you say you want to know about how we achieve intersegmental mobility. That's what's on everyone's mind right now is how do I achieve intrasegmental mobility? And the reason why that's important is what we see in motor control studies is that people who have back pain, even people who are going to go on to develop back pain, and even people who've had back pain and the pain is resolved, there's a common motor control observation from laboratory research studies which shows that people stiffen their spine. They seem to default from controlling their mobility intrasegmentally with the muscles that connect from the vertebrae below to the vertebrae above, and that would be like the interspinalis muscle, the rotatories, those very tall, small muscles that just connect just in between two vertebrae, not that span several vertebrae. And what those muscles are dependent on, or they're dependent on a number of things, but we're going to begin with the mechanoreceptors of the arthrokinetic reflex, which is reading hundreds of studies at this point. To the most, these mechanoreceptors on the joint capsule are all ever recognized. They only say there are mechanoreceptors on the joint capsule. And that's about it. They never go into the properties of those of what those mechanoreceptors are doing. But these two wires here are representing the type 1 and type 2 mechanoreceptors of the arthrokinetic reflex. There are type 3 and type 4 mechanoreceptors, but those are not active without chemical irritation or extreme motion of the joint beyond physiological range. And I'll just briefly mention that when this research was first introduced in the 60s and 70s, and then in lectures in the 80s, what they were looking for was bursts of activity from the sensory system to gate pain, and that has been largely disproven. And the type 4 mechanoreceptors of the arthrokinetic reflex, which were those were the mechanoreceptors which were supposed to provide that burst of nerve activity. That's never active in normal physiological motion, so we can forget that. What is important is these mechanoreceptors, they are sensitive primarily in anatomical neutral, in the upright position. And as you deviate from that upright position, just within 30% of the motion, from neutral to 30% in whichever direction they're going, of course, the knee, you're standing up, your knee is fully extended, and if you bend it 30 degrees, that's when those mechanoreceptors are the most active. So they're most active in the upright posture, which is what you would expect. And so what happens is,
Should we zoom in on this?
Now we're ready to zoom in on it.
Yeah, I'm going to zoom in. So I'll come. Okay.
So here we have, this is the type 1 arthrokinetic mechanoreceptor, and it attaches on the joint capsule. And at rest, it has tonic activity. It's firing at somewhere between 10 and 20 hertz. Although that's interesting academically, me sitting here, I may look like I'm not moving, but I am dynamically doing all sorts of gymnastics in order to maintain my upright posture. So that's just an academic statement that when this is at rest, it's never really at rest. But if you're doing research in a laboratory, you would see that if this joint is separated and laid on a table and it's actually really not moving, that this mechanoreceptor is going to be firing, and the type 2 mechanoreceptor is going to be silent. And as soon as you start to move, the mechanoreceptor is sensitive to stretch and pressure changes within this capsule. And it's going to alert the proprioceptive system that you're moving. And what it's going to do is it synapses directly with the motor nerve at the same level as the joint, it synapses with the motor nerve at the anterior horn cell, and it comes back out, and then it attaches to these muscles that I've been talking about, that are the muscles associated with that joint, and probably the larger muscles superficial to that, communicating that you're moving. Not only do they communicate with muscles on the same side, the ipsilateral side, they cross over and communicate with muscles on the other side, so that when you move, these receptors are saying, oh, we're side bending to the right side, and we're extending on the left side, and this is communicating with each other, and everyone's happy. Everyone knows what's going on. And then on top of that, intimately associated with that are the proprioceptors within inside the muscle, the intrafusal fibers of the muscle. So if we have muscles over here, and as you start to lean to the right side, these muscles on the left are being stretched, and that's activating the stretch reflex. Now, when I think about the stretch reflex, and everyone I've talked to, and maybe everyone I've talked to doesn't know very much. I don't know. I didn't. Maybe I haven't found the right people. I associated the stretch reflex with deep tendon muscle stretch reflexes, where you tap the tendon and the muscle jumps. And it actually does far more than that. That's really a disservice to how this really acts. When you start to move, those intrafusal fibers are very sensitive, and they're connected with the information that's coming from the joint through the arthrokinetic reflex. And the arthrokinetic reflex is modulating the response in the stretch reflex, because if you've ever tapped someone's tendon and evoked a muscle stretch reflex, it's a jump, it's a jerk. And what the information from the arthrokinetic reflex is in some cases, it's inhibiting that reflex, the stretch reflex, which is among the most, if not the most powerful, about the most powerful postural reflex. And it's modulating it so it's not jerky, smooths it out. At the same time, there are receptors in the tendon, the Golgi tendon organ, which I learned were only sensitive at the extremes of motion and would fire when there was to prevent an injury in the tendon. But in fact, they're far more sensitive to that. So when the person leans and they stretch the muscle, they activate the stretch reflex that's modulated by the information from the arthrokinetic reflex. It's also modulated by information coming from the Golgi tendon organ, which is sensitive to small levels of stretch, not the intense stretch that we learned. So when you're discussing the process of what it takes to move intrasegmentally, it's the communication between the stretch reflex, the Golgi tendon organs, the intrafusal fibers, which are the stretch reflex, the type 1 and type 2 mechanoreceptors of the arthrokinetic reflex, and the initial motion that occurs is an automatic response. It's sort of built-in programmed. It's called a central, I forgot the name of that, but we'll have to remember it. And then there's these automatic spinal reflexes that occur that are the initial part of the motion. And I'm talking within a few milliseconds, 5 milliseconds, less than 10 milliseconds. Very quickly, other processes come in, and there's information from other joints and other muscles. And the whole nervous system kicks in, and information from the brain. But initially, it's just information within the little unit that I discussed, the stretch reflex and the arthrokinetic reflex. And if all that's working properly, then a person can control their movement segmentally. And how we're maintaining balance is all these vertebrae are shifting very quickly back and forth and maintaining our balance with most of the activity we can control our balance with shifting our head. And it's the same process with the same reflexes, stretch reflex, arthrokinetic reflex, information that's coming from the mechanoreceptors in the joint. And that's how we would like to efficiently maintain balance. the what happens is if that is not a coordinated response, then the more superficial muscles kick in, and then people move with their spines stiff. And that's what we're discussing when we're talking about provoking the arthrokinetic reflex. We are stabilizing, trying to limit the motion in the joints above, and we're having people move above where we're stabilizing. And although we're like passively moving them, we're not actually passively moving them. They are actually controlling the motion and that level. If they can control it, that means they're using these intrasegmental muscles. What we find is that people with a problem, they stiffen their spine using the more superficial muscles that cross over multiple joints, and they present as stiff when we use the Bohr's evaluation technique, is what we're calling it, to provoke an aberrant reflex response in these muscles. When we try to move them and the person presents as stiff, that's an abnormal response, and that tells us that we need to do an intervention to restore that intrasegmental motion.